Pseudoexfoliative syndrome is diagnosed all over the world, and the climate and geographical location of the country do not play a significant role in the detection of this disease. For the first time, ocular manifestations of pseudoexfoliative syndrome were described by the Finnish ophthalmologist John Lindberg, who in 1917 described gray-blue flakes on the pupillary edge of the iris in 6.6% of elderly people, in 20% of patients with age-related cataracts, and in almost 50% of patients with chronic glaucoma. Vogt later diagnosed similar changes in the anterior capsule of the lens and called it senile exfoliation of the lens capsule, associating them with development. Other researchers have found similar changes in the iris, trabecular meshwork, ciliary body, ciliary ligament, ciliary belt, cornea, and conjunctiva. It was established that the presence of the lens is not a prerequisite for the development of pseudoexfoliative syndrome, as evidenced by the appearance of pseudoexfoliations in the eye many years after intracapsular lenses in pseudophakic eyes. The frequency of development of pseudoexfoliative syndrome increases with age. There are different cases of ocular manifestations of the syndrome depending on age. 0.7% in people aged 50 to 60 and 7.3% in people aged 80 and over. It has been established that in women without signs of glaucoma, pseudoexfoliation in the eye occurs significantly more often. Perhaps this is due to a longer life expectancy in women than in men. Pseudoexfoliations are localized on the surface of the anterior capsule of the lens, the anterior and posterior surfaces of the iris, ciliary processes, ciliary ligament, ciliary belt, in the corner of the anterior chamber, and sometimes on the posterior surface of the cornea and anterior hyaloid membrane. With pseudoexfoliative syndrome, all tissues of the front part of the eye are involved in the pathological process. The consequence of hypoxia of pseudoexfoliative syndrome is neovascularization of the iris, intrastromal hemorrhages, proliferation of cells of the corneal endothelium and their migration to the drainage zone. Pseudoexfoliative material in the human body, in addition to the eye, can also be found in the skin, heart, liver, kidneys, brain membranes, gallbladder. At the same time, histochemically and ultrastructurally, pseudoexfoliations are identical to the material found in the eyes. Slight dilation of the pupil after the use of mydriatics is the most characteristic feature of pseudoexfoliative syndrome. Ciliary ligament weakness increases the risk of lens dislocation, ciliary ligament rupture, and posterior lens capsule rupture. Patients with pseudoexfoliative syndrome also often experience complications in the postoperative period, increased intraocular pressure, a tendency to develop an inflammatory reaction and the formation of posterior synechiae, fibrin shedding, and the development of corneal epithelial endothelial dystrophy. The detection of secondary cataracts in pseudoexfoliative syndrome is also interesting. On average, in 11% of cases compared to 9% in normal cataracts. But their feature is that they usually develop only 1.5 to 2 years after extraction. The development of modern models of intraocular lenses and the improvement of the surgical technique made it possible to reduce the frequency of intraoperative complications and slightly shorten the period of rehabilitation of patients after cataract extraction. Modern ophthalmology attaches great importance to the study of risk factors affecting the probability of intraoperative detachment of the lens capsule from the ciliary ligament during cataract extraction in patients with ocular manifestations of pseudoexfoliative syndrome.